Hello everyone. My name is Karina Cabrita and I work at Cytognos as a product manager. So I've been working here for already 10 years and we have decided to prepare a presentation on the reporting, especially MMRD reporting and the importance of the parameters that need to be included in the report. So my colleague Maria Rodriguez, which is just next to me, she and other teammates, we prepared a presentation to wait.
Okay. Okay.
Just wait.
Welcome.
Welcome everyone.
Yes.
So my name is Karina Cabrita and I'm here with my colleague Maria Rodriguez and we are here to present what are the parameters which are important to include in a MRD reporting. Okay, so we prepared a very nice presentation that we hope is useful for everyone, and it's within the theme from the last presentation. So Maria, please present yourself.
Hi, good morning. This is Maria, and I will. I'm a product specialist of Cytognos for over 7 years. So, and I'm glad to be here, as Karina said, presenting how to report your data in measurable residual disease and how you can report this information with the best quality. So, thank you so much for joining us today.
Okay, so you can start the presentation now, please.
Welcome. Thank you all for coming to Welcome. Thank you all for coming to the session. I want to thank Paula Fernandez and also all the organizer of this ESCCA for giving Cytognos the opportunity to talk at and participate in the ESCCA 2021 virtual conference. My name is Maria Rodriguez and I am International Product Specialist at Cytognos. And today I will be the presenter of the session named State-of-the-Art Reporting for Measurable Residual Disease. So this is the conflict of interest disclosure. So we allow the ESCCA to publish this session in their website. So now let me start this session by mentioning the main challenges of MRD assessment. And then I will show you how we can overcome these challenges with a state-of-the-art report. Our main goal when studying MRD assessment is to detect if there is remaining disease because we want to treat the patients with a personalized therapy. But despite the clear need of MRD assessment, MRD assays bring different challenges. Technical difficulties could give misleading results. Sensitive and specific standardized methods for MRD determination are not widely available outside of specialized centers. And this can also be a drawback if in the specialized center they do not have access to this diagnosis information. And this lack of standardization means that the expertise of the operator plays a key part in the diagnosis of the patient. So our main aim when treating our patients is to cure them. But as I said, despite clear and novel therapies, patients still relapse. So as an example, children with acute leukemia, 15 to 20% of children with acute leukemia relapse, and implementing pediatric acute leukemia algorithms lead to substantial increase in the survival in adult patients with acute leukemia. Nevertheless, 40 to 50% of adult patients still relapse. So if we compare the disease to an iceberg, that means that we are not seeing a considerable part of the disease, despite the patient being in complete remission. That is why we need more sensitive techniques that allow us to see what's below the surface to detect measurable or formerly called minimal residual disease persisting below complete remission. Note the difference between not detectable and truly negative MRD. The term measurable residual disease has been suggested as a replacement of minimal residual disease because the detection threshold for the various diagnosis techniques are a moving target. The red line indicates the detection limit of cytomorphology. Then we have PCR with a sensitivity level of 10 to -3, and next generation flow and next generation sequences with a sensitivity level between 10 to -5. In-house availability and laboratory experience drive the choice between the different techniques at the moment. The second challenge is that the sensitivity of the MRD assays or the depth of response is very important to treat the patients with a personalized therapy. Patients can respond to the same treatment in different ways. There are patients that do not respond to therapy or they do in a suboptimal manner. And patients who achieve complete remission or even undetectable MRD may experience relapse. Thus, MRD follow-up is crucial for the identification of patients at high risk of relapse. In the last years, we have seen a lot of new therapeutic approaches, and this has increased a lot the survival of the patient. For example, multiple myeloma patients they have an overall survival from 2 to 3 years, and now it's up to 10 years in survival rate and in multiple myeloma patients. And as you can see in these images, the 5-year survival improved in all age group, but this improvement is more significant in younger patients, in patients younger than 50 years old. And you can see in this graphic how they have almost doubled their survival rate thanks to new therapeutic approaches and new improvement care. Therefore, this highlights the importance of MRD assessment and how this MRD allows clinicians to have a clearer orientation on what clinical decision they should make, which is patient, and provide them with a personalized therapy. In addition, for MRD detection, we should monitor the aberrant population. An extensive list of aberrant immunophenotypes have been described, including asynchronous marker expression. That is the expression of a marker before or later than expected during the maturation. We can also have cross-lineage, or the expression of an antigen that is usually expressed in a different cell lineage. We can have over or under expression, as well as a ectopic expression. That is the expression of a marker in a population in which is not usually expressed. The pathological cells at diagnosis may have multiple aberrant immunophenotypes, and we should follow all of them in order to increase the sensitivity of the MRD assay. However, MRD evaluation might be studied in referral laboratories, and it's not always possible to have access to this diagnosis information. So after therapy, the monophenotypic aberrancies in a diagnosis may be used as a starting point for MRD evaluation. However, immunophenotypic changes in the expression of at least one antigen between the diagnosis and the relapse were observed in acute leukemia, for example. Furthermore, the ability to discriminate leukemia cells from normal cells can be hampered by the treatment. Antigen-targeted therapies, for example, can result in the decreased expression or even the absence of an antigen that can be used for the identification of the neoplastic population. All these changes in the monophenotype can hinder the detection of the neoplastic cells and might lead to false negative results. On that topic, one of the greatest concerns is related to the quality of the sample. The bone marrow aspiration could lead to blood contamination and the estimation of the burden of neoplastic cells. Other issues such as sample aging, clotting, and degeneration due to improper shipping or storage conditions may also significantly affect the results. Evidence of compromised specimen quality includes the hemolysis as well as the presence of apoptotic cells. To make sure of the reliability of the MRD results, cutoffs to determine the positivity and negative of MRD results should be established. In that regard, the International Myeloma Working Group has defined for the assessment of multiple myeloma the 20 cell cutoff for the limit of detection as a minimum to identify the aberrant plasma cell population. And they have also defined that the aberrant population should have at least 50 cells in order to have a in order to obtain reproducible enumeration of cell population, and this is the lower limit of quantification. The International Myeloma also recommends the acquisition of 10 million cells to clearly discriminate between the positive and negative MRD assessment, and the importance of acquiring enough number of events is illustrated on these diagrams. So we can see in red the aberrant plasma cells, and in gray we also have the normal plasma cells. So as you can see, if we acquire less events, we are losing sensitivity, and it's more and more difficult to identify the aberrant plasma cells in between all the normal plasma cells, and therefore it's more difficult to identify or to evaluate the MRD assessment. All of these challenges make MRD analysis very difficult to interpret, and experienced operators are needed to correctly evaluate their MRD results. Therefore, challenging case analysis might carry an element of subjectivity. So, to recap, these are the main challenges we can face when evaluating MRD analysis. And how we can overcome these challenges with a state-of-the-art report. So let me use the multiple myeloma automatic report as an example of a state-of-the-art reporting. Aeroflow has designed and validated different reference databases, including one for the monitoring of minimal residual disease in multiple myeloma. So when comparing a new case with the multiple myeloma MRD database, the population identified are automatically compared with the normal reference ranges for both relative distribution and phenotypes. This information gives us an overview of the patient immune status, and the clinician can use this information to give patients a tailored therapy. Populations outside the normal reference ranges are easily identified because they appear in bold, similarly as in hemogram reports. And depending on the alteration and the affected population, we can conclude on the quality of the sample, the bone marrow immune regeneration, as well as the MRD assessment. For the bone marrow immune regeneration, the major pointers are the precursors and the nucleated red cells. For the quality of the sample, the most important indicators are the decrease in the mast cells, nucleated red cells, and precursors. The modulation is assessed using the frequency of the mast cells. So if they, for example, if the sample sent for MRD assessment is significantly modulated, the disease burden might be inaccurately assessed. And this matters because some treatments or other important clinical decisions are based on achievement of undetectable MRD. And the patient care might be compromised if such decisions are based on an accurate assessment of the MRD. In addition, the quality of the processing is automatically evaluated by the software by separating the breeds, doublets, and nucleated cells. A high percentage of the breeds, above 20%, could indicate inappropriate sample quality or processing errors. The MRD assessment is based on the presence or absence of aberrant plasma cells, but in order to know the exact frequency of these aberrant plasma cells, it's mandatory to identify all the nucleated cells present in the sample. The report also includes the limit of detection and the limit of quantification sensitivity levels, and they are calculated for each sample depending on the number of acquired cells. As I said, the acquisition of 10 million cells demonstrates an effective sensitivity close to 2 by 10 to minus 6 as described by the International Myeloma Working Group for the Assessment of Multiple Myeloma MRD. The report also includes the immunophenotype of the aberrant plasma cells. So after therapy, the monophenotypic aberrancies in a diagnosis might be used as a starting point for MRD evaluation. But in this case, the aberrant plasma cells phenotype is obtained from the comparison with the normal plasma cells included in the database. So therefore, in this case, the diagnosis information is not necessary. Finally, the report will include conclusion about the MRD assessment based on the presence or absence of pathological plasma cells. The report will also describe warnings if the sample is immodulated or if the number of events does not allow us to reach the required sensitivity. Conclusions of MRD positivity or MRD negativity can only be stated if the required sensitivity has been reached. And this is why the limit of detection and limit of quantification have to be taken into consideration. This is also particularly critical if a MRD negative result is obtained. If the result is negative for MRD, but not enough cells were analyzed, the decreased sensitivity of the detection should be properly annotated. Nevertheless, bone marrow aspirates are crucial for MRD assessment and should be analyzed even if we can find some small issues. However, deviation from the expected quality of the sample should be carefully annotated in order to avoid misinterpretation in the clinical practice. You can increase the accuracy and precision of our results by relying on databases created by experts. The automatic report will reveal slight numeric and phenotypic alterations that can be missed, and this is greatly helpful with interpretation of complicated cases that are close to the limit of detection. Finally, after we have performed the MRD evaluation, we can electronically sign the analysis and the report before sending the results to the clinicians, and we can assign different roles with specific roles for each user in the lab. So in this example, we have the technician that can first certify the analysis and then label the report as analyzed. Then we have the pathologist that can sign off the case and label the report as approved, and then issue when he or she is ready to send out the result to the clinicians. All this together can help you meet the quality compliance and standard requirements of your clinical laboratory. The automatic report is also available in different languages, which facilitate the implementation of this state-of-the-art reporting in any laboratory, regardless of your country. So this is how the state-of-the-art report can help you overcome the challenges of MRD evaluation. So to sum up, according to international consensus, the report should include the MRD level, plus the limit of detection and the limit of quantification of the assay, the proportion and number of neoplastic cells and normal cells, the immunophenotypic expression profile of the neoplastic cells if present, as well as the cell viability and the quality of the sample. This state-of-the-art report can be used for other studies, such as monitoring circulating tumor plasma cells, in peripheral blood for the diagnosis of multiple myeloma, or the screening of, for example, of chronic lymphoproliferative disorders, as well as acute leukemia. There is also available a state-of-the-art report for the screening of primary immunodeficiencies. So this is how the state-of-the-art reports can help you overcome the challenges of MRD assessment. And all of these state-of-the-art reports are available within Phenixite 2.0. Phenixite 2.0 is part of Cytognos Next Generation Flow Solutions, And we offer, in collaboration with Euroflow, a complete and scientific-based solution to cover all your needs in your clinical laboratory, including the support from our highly specialized technical team. So we hope that you have gained insight on how you can adopt this state-of-the-art report for the assessment of MRD in your lab. And please visit our booth if you want to know more about the state-of-the-art reporting and Cytognos next generation flow solution. Again, I want to thank all the organizers of the ESCCA for giving this opportunity to talk in the virtual conference of 2021.
Okay. Thank you so much for coming to our session. I really hope you enjoyed it. As you know, you have on the right side, you have a chat box where you can write all your questions. Fiona already asked if you can use the database with all the flow cytometers. So the databases were built with the files from Canto because it was what was available at that moment. It really also depends now that we are moving forward. The new databases most probably will be compatible with more cytometers. You can use it with Canto, and with Lyric you will have more check populations to verify, but you can still use it. With Navius we also tried it. You have more check populations because the difference is the 4-site scatter, not actually the populations. But anyway, you have to verify more events, but it's still less events than 10 million. But anyway, if you're interested in doing that with different files from different cytometers, just contact us and we can explain how to do it.
In that regard, Omnisite files are also compatible with Euroflow databases.
Yeah.
You want to use?
Yeah. It's just that just contact us and we can help you. Yeah, Olivier is asking if we tried with Cytek spectral instrument. So we haven't tried it yet, but if it's possible to make it compatible with the Aeroflow settings, so what is important, it doesn't matter the cytometer, is that you can put the populations in the same place in the MFI. So InfiniCyte will rescale the data, but if the 4-site scatter algorithm is really different, then you'll have more check populations for neutrophils, monocytes, and others like that. Okay. Can you? Bojan, I don't understand exactly the question. Mm-hmm. So you can work with. There's not a limit of events that you can process in InfiniCyte. So if you have 10 million events, you are able to see them. Mm-hmm. So there's no issue. So the requirement is the computer. Okay. So if you are working with 10 million events, then you should have a really, really good computer. Mm-hmm. If this was not the answer to your question, just please rewrite and we will see it. Okay, so Fiona, it's you're asking if the 4-site scatter is the most important parameters to match up. It's not the most important parameters for the databases because you are looking for other. So you're looking for the MFI markers, so I don't know, CD38, for example. But if you want to look at the complete sample, so the complete immunophenotype of a population, then you want to have your neutrophils or monocytes correctly classified. Mm-hmm. Even if they are in the check population, it's very easy to classify. So it's important to have less number of check populations, yes, but it's not important to have a correct classification. Mm-hmm. Please elaborate on what is stated on a MRD negative report. So if it's an MRD negative report, it will tell you that it was not possible to find an MRD positive population, and what was the LOD that you were evaluating. It will also tell you examples of the debris that you have, which might indicate that you have like a technical issue. And I think that's it. So, and it will tell you also if it's hemodiluted, for example, because this will affect the results. I don't I don't know. We can have a look later also, Leanne, about this. But from my memories, this is what appears.
Yeah.
Okay. So I think there's no more questions. There's just a clarification from our colleague Jesus. Oh, there's more questions now. Jesus just wants to clarify to Bojan that there's no minimum events to run. So there's no limit. So you can decide what you want to run in your cytometer, and Infinisight can process it. Just to take into consideration that the less events you have, the lower the sensitivity you will have also. There's a question: are you working on a solution to the problem of PET kappa lambda expression in cryotube? So we have no information about this. So yes. And I don't know exactly which tube you are mentioning, so I assume MMRD. Yeah. But we have no information about this. So the kappa and lambda are correctly separated. Maybe the shape is not exactly the same because of so it's not like a round population, but the identification is made correctly. Okay.
So also, Mona, if you can also, well, I think I write privately your. We can also contact you later, and so you can give us more information about this topic.
Okay. So, do you have more questions? We still have around 4 minutes that we can use to explain anything that you have doubts about.
Yes.
Anyway, we have a parallel room that's being managed by our colleague Jesus, where you can enter and ask any questions. So we have also a session about aerofoil panels later today. So if you have any question, you can ask it there also. Okay, we are also available in our booth, and most of you already have our emails, and you can contact us directly regarding this issue, this team. Sorry.
So again, as Karina said, thank you so much for joining us today in the session. So we have some couple of minutes left. So if you have any question or you want to review something, please feel free to write them in the chat.
No. So I think we can wrap up this session.
Okay, Bojan has another question.
Do we have 3 tubes for MRD? We have for MMRD and BCP-ALL MRD, we have 2 tubes. Okay. Actually, most of the tubes, they have common markers so that you can really confirm that, for example, if you have like 50 events or even less than those events, you have the reproducibility of both tubes. So it's like a confirmation. That's the reason why we have 2 tubes to verify the MRD. Okay.
And yes, also our colleague Jesus is writing that we are going to have a live demo of Omnisite in our sponsor room. So if you're welcome to join us also during this live demo.
Bojan, we can contact you later also to explain in more detail all the questions that you are having regarding MRD.
Oh.
Okay. Welcome.
Welcome, Bojan.
Okay.
So thank you so much again for joining us today, and I hope you enjoyed our session.
It it will finish now in 5 seconds. So
Thank you so much.